Hello, my name is Matthew McCoyd. I'm a neurologist at Loyola Medical Center, and I'm going to be going over the neurology section for the American Board of Internal Medicine examination. You can look at the neurology section in one of two ways. For many of you, neurology is going to be one of the more challenging topics for this examination because neurology is not part of your routine practice. If you gave me questions about the heart, the lungs, diabetes, it's not part of what I do as a neurologist, and it would be very challenging. For many of you, your main practice is internal medicine, and neurology is something you don't often encounter. What the board is going to ask you to do is have a basic understanding of common neurologic diagnoses and the basic management of it. What I'm going to try to do is walk you through the neurology topics that are outlined by your board and give you what I believe to be high-yield cases that will hopefully prepare you for the examination and minimize the time you need otherwise to study for neurology. We are going to go over a number of different topics, reviewing both the central and peripheral nervous system. Well, this lecture is case-based. I do want to take a moment just to give you an overview of neurology without getting too esoteric, but as a neurologist, I feel obligated to get slightly esoteric since that's my role. So I just want to start with how you approach cases that involve the nervous system or involve neurology. As a neurologist, I have a simple approach to most of my cases. Number one, is there a neurologic problem? Oftentimes that's the challenge, right? In trying to decide, does this patient need to see a neurologist? Is the problem somewhere in the nervous system? So number one, is there a neurologic problem? If we've decided there's a neurologic problem, does it involve the central nervous system or the peripheral nervous system? It is very unusual in neurology for disease states to affect both. Typically, most diseases will affect the central nervous system, which is the brain stem, and the spinal cord, or they will affect the peripheral nervous system, which is nerve, neuromuscular junction, and muscle. It's extremely rare that both systems get involved. Some things I find to be helpful in trying to make that determination. Number one, is it neurologic? Number two, central or peripheral? Things that help me. Altered mental status. If the patient has altered mental status, it has to be a problem with the brain. Are there any cortical findings? The things that make us who we are. So language, neglect, major problems with visual function, things that reflect the sort of outer aspect of the brain. Is there any evidence of an upper motor neuron sign? Right, so patients who are hyperreflexic, particularly upgoing toes or Babinski's. If you see an upgoing toe, the problem has to be in the central nervous system and it has to involve the cortical spinal tract. Nothing else will do it. Does the patient report a sensory level? They say they're numb somewhere in the torso. They're numb somewhere from the jawline to the pelvis. If they say there's numbness in the torso or a sensory level, the problem has to be in the spinal cord with almost no exceptions. And to some extent, movement disorders. The movement disorders can be fairly complex. They typically reflect a problem somewhere in a movement center such as the basal ganglia or the cerebellum, but they generally reflect problems inside the brain. For the peripheral nervous system, things that can be helpful are there lower motor neuron signs, particularly severe atrophy, muscle weakness, absent reflexes? Do the symptoms involve the distribution of a single nerve that I can clearly outline? Things I hear commonly from medical students and from our residents that I find to be less helpful: cranial nerve findings. Cranial nerves don't localize to central or peripheral nervous system. It can be a little bit confusing. Symmetry of symptoms doesn't help me make that determination. A Romberg sign simply reflects there's a problem with proprioception, but I don't know if it's central or peripheral. And the same is true for vibratory sense. Absent vibratory sense doesn't mean there's a problem in the dorsal columns necessarily. It could just as easily be in the peripheral nervous system. But again, the kind of main point of emphasis for me, number one, is there a neurologic issue? If there is it the central nervous system or the peripheral nervous system? Because it typically is only going to be in one of those. For the central nervous system, the mnemonic I like to use is the simple mnemonic. Right? So if I've decided the problem is in the central nervous system, number one, is it a structural issue? Is something wrong with the structure of the brain? Right? Things like stroke, subdural hematomas, mass lesions are structural problems that alter the way the brain can function. I can typically see that in imaging. Is there an infectious process, meningitis, for example, or an encephalitis, or an inflammatory process, things like multiple sclerosis, that can affect the function of the brain? I can also typically see these on imaging or through studies like spinal fluid. Is there a metabolic derangement, hypo or hyperglycemia, or did we cause it through a medication that we've ever given the patient or taken away from the patient? Is it a paroxysmal disorder, something that comes and goes, things like seizures, cardiac arrhythmias, migraine headaches, Things that are present, they may be normal in between the episodes, they come and go and can cause neurologic dysfunction. Is there a late onset neurodegenerative condition? Things like dementia, and many of the movement disorders that are neurodegenerative and progressive in nature. Or early onset, things like leukodystrophies, which I would not expect to be covered by the internal medicine examination. So we're going to go through a couple of cases to highlight some of the high-yield topics that are outlined in your board exam. I want to start with a case, and I want you to look for some of the differences here in these cases as I present them. A 67-year-old male presents to the emergency department for the sudden onset of weakness and speech difficulties. The patient is awake and alert, but does not answer any questions, only staring at the examiner. His wife, who is with him, states the symptoms started exactly 1 hour ago. On examination, there's weakness of the right lower face and right arm. The right forehead appears to move normally, and eye movements are normal. Patient's blood pressure is 126/82 with a pulse of 65. He is not on any anticoagulant therapy and has a normal PT and INR. Blood glucose is 98. A non-contrast head CT is interpreted as normal. So, which of the following treatments is considered most appropriate? Tissue plasminogen activator, IV heparin, aspirin, low-dose prednisone, or high-dose intravenous methylprednisolone? Your best answer here is going to be A, tissue plasminogen activator. And as we look at this case, though it may be important to recognize that this patient qualifies for TPA, the most important thing is to recognize, number one, this patient has symptoms consistent with a stroke, and we know the onset or timing. And that may be the critical thing they ask you to recognize. The patient's symptoms are less than 3 hours old. There's clear evidence that the patient is aphasic and has weakness of the face and the arm, very consistent with left hemispheric stroke. For these patients, TPA is indicated. IV heparin is not recommended for any form of stroke, acutely or as a prophylactic. Aspirin is appropriate for stroke, but in this case, TPA is more appropriate since the stroke was within the last 3 hours. Low-dose or high-dose prednisone would not be indicated for stroke, but would be for other neurologic conditions. As you think about stroke, a few things to highlight in this case. Number one is testing. Important take-home point is that the CT scan for acute stroke is normal. It's often very confusing for many students. The idea is that the patient's had a stroke, the CT scan should be abnormal. CTs are typically normal for about the first 24 hours after a stroke. The reason we do CT scans is to look for evidence of a hemorrhage, which will dramatically change our management. So for acute stroke, the CT scan should be done immediately and it should be normal. Many centers currently are adding CT angiograms at the same time to look for evidence of large vessel ischemia or occlusion, and those patients may qualify for emergent thrombectomy. An MRI scan is a much more detailed picture and unfortunately is much slower. A CT scan can be done in a matter of minutes. An MRI scan will typically take over an hour to complete, and time is of the essence. In terms of treatment, when you look at these test questions, a very important point is that they give you the onset of the symptom. There's a reason they're telling you that. There's a reason they're telling you the exact time that the stroke symptoms started. TPA is indicated at least within the first 3 hours. There are some more recent guidelines allowing this window to be extended, but the FDA approval for TPA is within the first 3 hours. So while in common practice, and you may see this in your place that you work or train, you may see TPA given at longer time intervals. The FDA approval is for 3 hours for TPA. Who can't get TPA is any patient who would be at high risk for bleeding. So patients who are already anticoagulated, for example, or patients who have no known onset for their symptoms. For stroke, if TPA is contraindicated, aspirin is almost always the answer. Doesn't matter the dose, 160 to 325 is generally recommended. Chronically, for the treatment of stroke, aspirin or clopidogrel are as monotherapy are recommended following most stroke types. In terms of looking for risk assessment, what should we look for in a patient who's had a stroke? The major risk factors for stroke include hypertension, diabetes, hyperlipidemia, sleep apnea, smoking, and heavy alcohol use. Patients who've had a stroke, we're trying to prevent the second stroke, and so recommendations and guidance to the patient on how to reduce these risk factors and treat them is very important. If the patient has atrial fibrillation, it is almost always recommended that they go on some form of anticoagulation. They're also covered in the cardiology section. The CHADS-2 VAS score, it can be used as a guideline for starting patients in anticoagulation. And then the answer is patients with AFib who've had a stroke almost always are indicated for anticoagulation. Other key points from this case to look for. Number one, the patient has only lower face weakness. If you go back to your medical school, remember that the facial nerve does something unusual and that the forehead has bilateral innervation. So the upper part of the face is spared in stroke. If there's a stroke, which is an upper motor neuron damage, only the lower face is affected. For lower motor neuron, or Bell's palsy, the entire face will be affected, just because of that bit of unusual anatomy. The patient also shows evidence of some aphasia, which is an impairment in language function. There are 4 major types of aphasia. A Broca's aphasia, with intact comprehension but non-fluent speech. The patient can understand you, but is very frustrated trying to give you an answer. A Wernicke's aphasia, where the patient can speak fluently, but with paraphasic errors, and they oftentimes have a word salad or not making any sort of sense. A global aphasia, with severe impairment of comprehension, repetition, or output. The patient cannot understand and cannot speak. Or a conduction aphasia, where there's a disproportionate disruption of repetition. Give the patient a series of things to repeat, and they will have a challenge doing so.